Inflammation status. CRP, ESR, PCT. 1. C-reactive protein. CRP. Purpose. CRP is a protein produced by the liver in response to inflammation. It is a general marker used to detect acute inflammation and monitor chronic inflammatory conditions. Normal range, less than 1.0 mg per liter for low risk, 1.0 to 3.0 mg per liter for average risk, less than 3.0 mg per liter for high risk for cardiovascular disease. Elevated CRP. Acute infections, bacterial or viral infections can raise CRP levels. Chronic inflammatory diseases, conditions such as rheumatoid arthritis, lupus, and inflammatory bowel disease. Cardiovascular disease, elevated CRP is associated with a higher risk of heart attacks and strokes. Trauma or surgery, tissue injury can increase CRP. Cancer, certain types of cancer, especially those that cause inflammation, can elevate CRP. Obesity, increased fat tissue can cause low-grade chronic inflammation. Smoking, increases CRP due to inflammatory response in blood vessels. Decreased CRP. Anti-inflammatory medications, use of NSAIDs, corticosteroids, or statins can lower CRP. Effective treatment, successful treatment of the underlying inflammatory condition. Normal finding, low CRP is typically a normal result and suggests the absence of significant inflammation. 2. Erythrocyte sedimentation rate ESR. Purpose, measures the rate at which red blood cells settle in a tube over an hour. It is a nonspecific marker of inflammation used to detect and monitor inflammatory diseases. Normal range, 0 to 15 mm per hour for men, 0 to 20 mm per hour for women, may be slightly higher for older adults. Elevated ESR. Chronic inflammatory diseases, rheumatoid arthritis, lupus, and temporal arteritis. Infections, bacterial infections, tuberculosis. Cancers, lymphoma, multiple myeloma. Kidney disease, chronic kidney disease can elevate ESR. Anemia, certain types of anemia, like normocytic or macrocytic anemia. Pregnancy, ESR naturally increases during pregnancy. Vasculitis, inflammation of blood vessels. Decreased ESR. Polycythemia vera, increased red blood cell mass lowers ESR. Sickle cell anemia, abnormally shaped red cells do not settle quickly. Leukocytosis, high white blood cell count can interfere with sedimentation. Heart failure, can cause a reduction in ESR. Hypofibrinogenemia, low fibrinogen levels reduce ESR. 3. Procalcitonin PCT. Purpose, procalcitonin is a protein that increases significantly in bacterial infections, particularly sepsis. It is used to distinguish bacterial infections from other causes of inflammation. Normal range, less than 0.1 nanograms per milliliter. Elevated PCT. Bacterial sepsis, significant increase in response to systemic bacterial infection. Severe bacterial infections, pneumonia, meningitis, or severe urinary tract infections. Severe trauma or surgery, can cause a temporary increase in PCT. Pancreatitis, inflammation of the pancreas may elevate PCT. Kidney injury, severe acute kidney injury can cause elevated PCT. Normal or decreased PCT. Viral infections, PCT is usually not elevated in viral infections. Successful antibiotic treatment, a decrease in PCT indicates a positive response to treatment. Autoimmune diseases, PCT may not be elevated even in the presence of inflammation.
Complete blood count. WBC, RBC, HB, HCT, MCV, MCH, MCHC, RDW, PLT. 1. White blood cell count. WBC. Purpose, assesses immune function and detects infections, inflammation, and hematologic conditions. Normal range, 4,000 to 11,000 cells per microliter. Leukocytosis. Causes: infections, bacterial, viral, fungal, or parasitic infections. Inflammation. Conditions such as rheumatoid arthritis or inflammatory bowel disease. Leukemia. Acute or chronic leukemia causing increased white blood cell production. Trauma. Physical injury leading to an inflammatory response. Stress. Physical or emotional stress can temporarily increase WBC count. Steroid use. Corticosteroids can elevate WBC count. Allergies. Allergic reactions can increase eosinophils, a type of white blood cell. Autoimmune diseases. Conditions like systemic lupus erythematosus (SLE) or vasculitis can cause elevated WBC counts. Chronic myeloid leukemia (CML), a type of cancer affecting blood and bone marrow. Myeloproliferative disorders. Conditions like polycythemia vera affecting blood cell production. Leukopenia. Causes: bone marrow failure. Conditions like aplastic anemia or myelodysplastic syndromes where bone marrow does not produce sufficient WBCs. Viral infections. Certain viruses, such as HIV, can decrease WBC counts. Severe bacterial infections, sepsis, overwhelming infections can deplete white blood cells. Autoimmune conditions. Diseases like systemic lupus erythematosus (SLE) can cause WBC destruction. Malnutrition. Lack of essential nutrients can impair white blood cell production. Certain medications, chemotherapy, immunosuppressants, and other drugs can lead to decreased WBC counts. Hypersplenism. Overactive spleen can sequester WBCs. Congenital neutropenia. Genetic disorders affecting white blood cell production. 2. RBC. Red blood cell count. Purpose: evaluates oxygen carrying capacity in anemia, polycythemia, and hydration status. Normal range: 4.7 to 6.1 million per microliter for men, 4.2 to 5.4 million per microliter for women. Polycythemia. Causes: polycythemia vera, a blood cancer causing increased RBC production. Chronic hypoxia. Conditions like chronic obstructive pulmonary disease (COPD) or living at high altitude. Dehydration. Reduced plasma volume leading to a relative increase in RBC count. Lung disease. Conditions causing low oxygen levels can stimulate RBC production. Congenital heart disease. Some heart defects can lead to increased RBC production. Smoking. Anemia. Causes: blood loss, trauma, surgery, menstruation. Iron deficiency anemia. Insufficient iron leading to decreased RBC production. Vitamin B12 deficiency. Impaired RBC production due to lack of vitamin B12. Folic acid deficiency. Reduced RBC production due to lack of folic acid. Chronic bleeding. Conditions like peptic ulcers or heavy menstrual bleeding. Bone marrow disorders. Conditions like aplastic anemia or leukemia. Chronic kidney disease. Reduced erythropoietin production leading to anemia. Hemolytic anemia. Destruction of RBCs due to autoimmune diseases or infections. 3. Hemoglobin. HB. Purpose: measures the oxygen-carrying protein in RBCs and assesses anemia and polycythemia. Normal range: 13.8 to 17.2 grams per deciliter for men, 12.1 to 15.1 grams per deciliter for women. Polycythemia. Causes: smoking. Polycythemia vera, a condition causing excessive RBC production. Chronic lung disease, low oxygen levels stimulating increased hemoglobin production. Living at high altitudes, adaptation to low oxygen levels. Anemia. Causes: iron deficiency anemia, reduced hemoglobin due to insufficient iron. Vitamin B12 deficiency, decreased hemoglobin due to impaired RBC production. Folic acid deficiency, lower hemoglobin levels due to impaired RBC production. Chronic disease anemia, associated with chronic infections or diseases. Acute blood loss, trauma or surgery leading to reduced hemoglobin levels. Hemoglobinopathies. Renal disease. 4. Hematocrit. HCT. Purpose: proportion of RBCs in blood, assesses anemia, polycythemia, and hydration status. Normal range: 40.7 to 50.3% for men, 36.1 to 44.3% for women. Polycythemia. Causes: dehydration, high altitude, congenital heart disease, erythropoietin-use. Polycythemia vera, excessive RBC production. Dehydration, reduced plasma volume increases hematocrit. Chronic lung disease, low oxygen levels increase RBC production. Anemia. Causes, blood loss, nutritional deficiencies, chronic kidney disease, hemolysis. Iron deficiency anemia, reduced hematocrit due to decreased RBC count. Chronic bleeding, loss of blood leads to lower hematocrit. Bone marrow disorders, impaired RBC production decreases hematocrit. Overhydration, increased plasma volume dilutes RBCs. 5. Mean corpuscular volume. MCV. Purpose, measures the average size of red blood cells. Normal range, 80 to 100 FL. Macrocytic anemia. Causes, vitamin B12 deficiency, impaired DNA synthesis leads to larger RBCs. Folic acid deficiency, similar to B12 deficiency, results in larger RBCs. Liver disease, hepatic dysfunction affecting RBC production. Microcytic anemia. Causes, iron deficiency anemia, smaller RBCs due to inadequate iron. Thalassemia, genetic disorders affecting hemoglobin synthesis. Chronic disease anemia, anemia of chronic disease often features microcytic RBCs. 6. Mean corpuscular hemoglobin. MCH. Purpose, measures the average amount of hemoglobin per red blood cell. Normal range, 27 to 31 pg. Hyperchromic anemia. Causes, macrocytic anemia, increased hemoglobin content in larger RBCs. Hypochromic anemia. Causes, iron deficiency anemia, decreased hemoglobin content in smaller RBCs. Thalassemia, reduced hemoglobin production. 7. Mean corpuscular hemoglobin concentration. MCHC. Purpose, measures the average concentration of hemoglobin in red blood cells. Normal range, 33 to 37 grams per deciliter. Hereditary spherocytosis. Causes, hereditary spherocytosis, increased concentration due to spherical RBCs. Hypochromic anemia. Causes, iron deficiency anemia, reduced hemoglobin concentration. Thalassemia, decreased hemoglobin concentration. 8. Red cell distribution width. RDW. Purpose, assesses the variation in red blood cell size. Normal range, 11.5 to 14.5%. Anisocytosis. Causes, iron deficiency anemia, variation in RBC size. Vitamin B12 deficiency, increased variation in RBC size. Recent blood loss, increased RDW due to new, different-sized RBCs. 5. Platelets. PLT. Purpose, essential for blood clotting and wound healing. Assesses risk for bleeding or thrombosis. Normal range, 150,000 to 450,000 cells per microliter. Thrombocytosis. Causes, infection, iron deficiency, myeloproliferative disorders. Primary thrombocythemia, a type of myeloproliferative disorder where the bone marrow produces too many platelets. Reactive thrombocytosis, secondary to inflammation, infection, or iron deficiency. Hemorrhage recovery, after significant blood loss, platelet count may temporarily increase. Splenectomy, removal of the spleen can lead to elevated platelet counts. Chronic inflammatory diseases, conditions such as rheumatoid arthritis or inflammatory bowel disease. Malignancies, certain cancers, like leukemia or lymphomas, can cause elevated platelet counts. Thrombocytopenia. Causes, viral infections. Bone marrow disorders, conditions like aplastic anemia, leukemia, or myelodysplastic syndromes affecting platelet production. Autoimmune diseases, conditions such as immune thrombocytopenic purpura ITP where antibodies destroy platelets. Sepsis, systemic infection causing platelet consumption. Liver disease, chronic liver diseases like cirrhosis can affect platelet production. Hypersplenism, an enlarged spleen sequesters platelets. Drug-induced, medications such as heparin or certain antibiotics can cause thrombocytopenia. Vitamin B12 or folate deficiency, impaired production of platelets due to deficiencies.
Blood coagulation tests. PT, APTT, INR, TT, fibrinogen. 1. Prothrombin time. PT. Purpose, assesses the extrinsic and common pathways of the coagulation cascade, used to evaluate clotting function and monitor anticoagulant therapy. Normal range, 11 to 13.5 seconds. Prolonged PT. Causes. Vitamin K deficiency, essential for the synthesis of clotting factors. Biliary obstruction, reduces bile necessary for vitamin K absorption. Liver disease, impaired production of clotting factors in chronic liver disease. Anticoagulant therapy, use of medications like warfarin. Disseminated intravascular coagulation. DIC, a condition causing systemic coagulation. Factor deficiencies, deficiencies in clotting factors such as factor VII. Shortened PT. Causes. Vitamin K excess, rare, but can occur with excessive supplementation. Increased clotting factors, conditions such as pregnancy or certain cancers leading to increased factors. 2. Activated partial thromboplastin time. APTT. Purpose, assesses the intrinsic and common pathways of the coagulation cascade, used to evaluate clotting function and monitor heparin therapy. Normal range, 30 to 40 seconds. Prolonged APTT. Causes. Hemophilia, genetic disorders affecting clotting factors 8 or 9. Heparin therapy, anticoagulant therapy affecting the intrinsic pathway. Lupus anticoagulant, presence of antibodies interfering with clotting. Vitamin K deficiency, affects factors in the intrinsic pathway. Factor deficiencies, deficiencies in factors such as factor 11 or 12. Shortened APTT. Causes. Increased clotting factors, conditions causing increased levels of intrinsic pathway factors. Technical error, incorrect sample handling or lab error. 3. International Normalized Ratio. INR. Purpose, standardizes PT results regardless of testing methods, used to monitor warfarin therapy. Normal range, 0.8 to 1.2. Increased INR. Causes. Anticoagulant therapy, overdose or high doses of warfarin. Vitamin K deficiency, impaired synthesis of clotting factors. Liver disease, impaired production of clotting factors. Increased risk of bleeding due to widespread clotting. Decreased INR. Causes. Inadequate anticoagulant therapy, insufficient dose of warfarin. Excess vitamin K, oversupplementation can reduce INR. Clotting disorders, conditions that lead to increased clotting tendency. 4. Thromboplastin time. TT. Purpose, assesses the final phase of the coagulation cascade, measures the time for blood to clot after the addition of thromboplastin. Normal range, 14 to 16 seconds. Prolonged TT. Causes. Systemic clotting leading to consumption of clotting factors. Fibrinogen deficiency, low levels of fibrinogen affecting clot formation. Heparin therapy, interferes with the clotting process. Shortened TT. Causes. Increased fibrinogen, conditions causing elevated fibrinogen levels. 5. Fibrinogen. Purpose, fibrinogen is a blood plasma protein that's a precursor to fibrin, crucial for blood clot formation. Elevated levels indicate acute phase reactions during inflammation. Normal range, 200 to 400 mg per deciliter. Elevated fibrinogen. Causes. Acute inflammation, part of the body's response to infection or injury. Chronic inflammatory diseases, rheumatoid arthritis, lupus. Cardiovascular disease, high fibrinogen is a risk factor for heart disease. Pregnancy, natural elevation during pregnancy. Obesity, chronic inflammation associated with obesity increases fibrinogen. Cancer, certain cancers, particularly those causing tissue damage. Acute phase reaction, response to trauma or infection. Decreased fibrinogen. Causes. Liver disease, impaired synthesis due to cirrhosis or hepatitis. DIC, Consumption of fibrinogen in widespread clotting. Genetic disorders, afibrinogenemia or hypofibrinogenemia. Severe malnutrition, reduced protein synthesis.
Lipid status. Cholesterol, triglycerides, HDL, LDL. Purpose: assesses the levels of different fats in the blood, providing insight into nutritional status, cardiovascular health, and metabolism. High cholesterol. LDL. Triglycerides, risk for atherosclerosis, coronary artery disease, stroke. High HDL, protective against heart disease. Low HDL, increased cardiovascular risk. 1. Total cholesterol. Normal range, less than 200 mg per deciliter. Hypercholesterolemia. Causes: hyperlipidemia, high-fat diets or genetic conditions like familial hypercholesterolemia. Hypothyroidism, slowed metabolism increases cholesterol levels. Liver disease, cholestasis can elevate cholesterol. Nephrotic syndrome, increased production of lipoproteins. Hypercholesterolemia. Causes: hyperthyroidism, increased metabolism lowers cholesterol. Liver disease, severe liver disease affects cholesterol synthesis. Malabsorption, conditions that impair fat absorption, such as celiac disease. Malnutrition, inadequate intake of dietary fats. 2. Triglycerides. Normal range, less than 150 mg per deciliter. Hypertriglyceridemia. Causes: obesity, excess caloric intake. Diabetes mellitus, poor glycemic control increases triglycerides. Alcohol use, excessive intake increases triglyceride production. Chronic kidney disease, impaired triglyceride clearance. Pancreatitis, can be both a cause and consequence of high triglycerides. Hypotriglyceridemia. Causes: malnutrition, insufficient caloric intake. Hyperthyroidism, increased metabolism lowers triglycerides. Chronic obstructive pulmonary disease. COPD, can reduce triglyceride levels. Malabsorption, conditions affecting fat absorption. 3. HDL. High-density lipoprotein. Normal range, more than 40 mg per deciliter for men, more than 50 mg per deciliter for women. Hyperalpha-lipoproteinemia. Causes: genetic factors, familial hyperalpha-lipoproteinemia. Regular exercise, increases HDL levels. Moderate alcohol consumption, increases HDL levels. Hypoalpha-lipoproteinemia. Causes: sedentary lifestyle, low physical activity decreases HDL. Smoking, reduces HDL levels. Diabetes mellitus, poor glycemic control lowers HDL. Obesity, particularly abdominal obesity reduces HDL. 4. LDL. Low density lipoprotein. Normal range, less than 100 mg per deciliter. Hyperbetalipoproteinemia. Causes: atherosclerosis, associated with plaque formation. Dietary factors, high saturated fat and cholesterol intake. Genetic disorders, familial hypercholesterolemia. Hypothyroidism, reduces LDL clearance. Hypobeta-lipoproteinemia. Causes: hyperthyroidism, increased metabolism lowers LDL. Malabsorption, impaired absorption of dietary fats. Chronic illness, conditions like cancer or severe infection. Liver disease, affects LDL synthesis.
Nutritional status. Albumin, prealbumin, transferrin, total protein. 1. Albumin. Purpose: albumin is a protein produced by the liver and is a key indicator of nutritional status, liver function, and overall health. It helps maintain oncotic pressure and transports hormones, vitamins, and drugs. Normal range, 3.5 to 5.0 grams per deciliter. Hyperalbuminemia. Causes: dehydration, concentration of albumin increases when fluid levels decrease. Severe infections, in some cases, acute infections can cause elevated albumin levels due to increased production. Anabolic steroid use, can increase albumin synthesis. Hypoalbuminemia. Causes: malnutrition, lack of protein intake affects albumin synthesis. Liver disease, conditions like cirrhosis or hepatitis reduce albumin production. Kidney disease, conditions like nephrotic syndrome where albumin is lost through urine. Chronic inflammatory diseases, conditions like chronic infections, cancer, or autoimmune diseases that increase protein breakdown. Heart failure, fluid overload dilutes albumin. Gastrointestinal disorders, conditions such as Crohn's disease, celiac disease, or protein-losing enteropathy. Severe burns, protein loss due to skin damage. 2. Prealbumin. Purpose: prealbumin is a more sensitive indicator of recent nutritional status, often used to assess malnutrition or monitor the effectiveness of nutritional interventions. Normal range, 15 to 36 mg per deciliter. Increased prealbumin. Causes: chronic kidney disease, reduced clearance can increase prealbumin levels. Hodgkin's disease, may increase levels due to the liver's response to inflammation. Decreased prealbumin. Causes: acute or chronic illness, conditions like infections, inflammation, or trauma that deplete protein stores. Malnutrition, especially in cases of protein-calorie malnutrition. Liver disease, impaired production due to hepatic dysfunction. Inflammatory states, conditions such as sepsis or surgery that increase protein catabolism. Burns, severe burns can cause a significant decrease in prealbumin levels. 3. Transferrin. Purpose: transferrin is a protein that binds and transports iron in the blood. It is an indirect marker of nutritional status, particularly protein status, and iron stores. Normal range, 200 to 400 mg per deciliter. Hypertransferrinemia. Causes: iron deficiency anemia, increased transferrin as the body tries to maximize iron transport. Pregnancy, increases in the second and third trimesters due to hormonal changes. Estrogen therapy, estrogen increases transferrin synthesis. Hypotransferrinemia. Causes: chronic illness, inflammatory conditions like chronic kidney disease or malignancy. Liver disease, conditions like cirrhosis impair transferrin production. Protein-calorie malnutrition, decreased protein synthesis. Iron overload, conditions like hemochromatosis where iron is in excess. 4. Total protein. Purpose: measures the total amount of albumin and globulin in the blood, indicating overall nutritional status and liver function. Normal range, 6.0 to 8.3 grams per deciliter. Hyperproteinemia. Causes: chronic inflammation, conditions like rheumatoid arthritis or lupus. Infections, chronic infections can elevate total protein. Multiple myeloma, overproduction of abnormal proteins. Dehydration, concentrated levels of protein due to reduced plasma volume. Hypoproteinemia. Causes: liver disease, impaired synthesis of proteins. Kidney disease, protein loss through urine in nephrotic syndrome. Malabsorption, conditions like celiac disease or inflammatory bowel disease. Malnutrition, inadequate protein intake or absorption. Acute infections, can temporarily lower protein levels due to catabolism.
Electrolytes, mineral status. Na, K, Cl, Ca, Mg, P, iron, Cn. 1. Sodium. Purpose: essential for maintaining fluid balance, nerve function, and muscle contractions. Normal range, 135 to 145 mEq per liter. Hypernatremia, causes: dehydration, vomiting, diarrhea, excessive sweating, or insufficient water intake. Diabetes insipidus, impaired kidney response to antidiuretic hormone. ADH, causing excessive urination. Hyperaldosteronism, overproduction of aldosterone leading to sodium retention. Cushing's syndrome, increased cortisol levels can cause sodium retention. Excessive salt intake, high dietary sodium or excessive saline administration. Kidney dysfunction, impaired sodium excretion. Symptoms: thirst, confusion, muscle twitching, seizures, coma. Hyponatremia. Causes: SIADH. Syndrome of inappropriate antidiuretic hormone secretion. Excess ADH causes water retention and dilution of sodium. Heart failure, fluid overload dilutes sodium. Cirrhosis, fluid retention due to liver disease dilutes sodium. Addison's disease, insufficient production of aldosterone leading to sodium loss. Diuretics, excessive use can lead to sodium loss. vomiting or diarrhea, loss of sodium through gastrointestinal fluids. Chronic kidney disease, impaired ability to excrete water can lead to dilutional hyponatremia. Symptoms: nausea and vomiting, headache, confusion, seizures, coma. 2. Potassium. K. Purpose, crucial for nerve conduction, muscle function, and maintaining normal heart rhythm. Normal range, 3.5 to 5.0 mEq per liter. Hyperkalemia? Causes: acute or chronic kidney failure, reduced ability to excrete potassium. Addison's disease, reduced aldosterone leads to potassium retention. Potassium-sparing diuretics, medications like spironolactone can increase potassium levels. Rhabdomyolysis, muscle breakdown releases potassium into the bloodstream. Hemolysis, destruction of red blood cells releases intracellular potassium. Metabolic acidosis, hydrogen ions shift into cells, causing potassium to move out of cells into the blood. Excessive potassium intake, through diet or supplements. Medications: ACE inhibitors, ARBs, NSAIDs. Symptoms: muscle weakness, fatigue, nausea, cardiac arrhythmias, for example, bradycardia, ventricular fibrillation, paralysis. Hypokalemia. Causes: diuretics, loop and thiazide diuretics cause potassium loss. Vomiting and diarrhea, gastrointestinal losses. Hyperaldosteronism, excessive aldosterone causes potassium excretion. Cushing's syndrome, increased cortisol promotes potassium loss. Magnesium deficiency, low magnesium can lead to potassium wasting. Alkalosis, potassium shifts into cells to exchange for hydrogen ions. Inadequate dietary intake, low potassium diet. Insulin administration, causes potassium to shift into cells. Symptoms: muscle cramps, fatigue, constipation, weakness, cardiac arrhythmias, for example. Tachycardia, atrial fibrillation, paralysis. 3. Chloride. Cl. Purpose: helps maintain acid-base balance, osmotic pressure, and proper hydration. Normal range, 96 to 106 mEq per liter. Hyperchloremia. Causes: dehydration, loss of body water increases chloride concentration. Hypernatremia, associated with high sodium levels. Metabolic acidosis, excessive loss of bicarbonate ions. Respiratory alkalosis, compensatory chloride retention. Renal tubular acidosis, kidneys' inability to excrete acids. Excessive saline administration, high chloride from intravenous fluids. Symptoms: weakness, deep, rapid breathing, dehydration symptoms. Dry mucous membranes, decreased skin turgor, high blood pressure, kidney stones in chronic cases. Hypochloremia. Causes: vomiting, loss of gastric acid, hydrochloric acid. Metabolic alkalosis, loss of hydrogen ions. H+ leads to compensatory chloride excretion. Diuretic use, especially thiazide or loop diuretics. Cystic fibrosis, chloride transport defect. Chronic respiratory acidosis, retention of bicarbonate leads to chloride loss. Addison's disease, aldosterone deficiency reduces chloride reabsorption. Overhydration, dilutes chloride concentration. Symptoms: muscle cramps, twitching, shallow breathing, hypotension, dehydration symptoms, confusion. 4. Calcium. Ca. Purpose: vital for bone health, muscle contraction, nerve signaling, kidney function, parathyroid function, and blood clotting. Normal range, 8.5 to 10.5 milligrams per deciliter. Hypercalcemia. Causes: hyperparathyroidism, overactive parathyroid glands. Malignancy, breast cancer, lung cancer, multiple myeloma. Excessive vitamin D, oversupplementation or granulomatous disease. Thiazide diuretics, increase renal calcium reabsorption. Sarcoidosis, granulomas can produce vitamin D. Bed rest. Symptoms: nausea, vomiting, constipation, polyuria, dehydration, confusion, arrhythmias, bone pain, fractures. Hypocalcemia. Causes: hypoparathyroidism, surgical removal or autoimmune destruction of parathyroid glands. Vitamin D deficiency, inadequate intake or synthesis. Chronic kidney disease, impaired activation of vitamin D. Magnesium deficiency, required for PTH secretion. Pancreatitis, saponification of calcium. Hypoalbuminemia, low albumin affects calcium binding. Diuretics, increased renal excretion. Symptoms: muscle cramps, tetany, paresthesia, seizures, Chvostek's sign, Trousseau's sign, cardiac arrhythmias. 5. Magnesium. Mg. Purpose: involved in over 300 enzymatic reactions, including protein synthesis, muscle and nerve function, blood glucose control, and blood pressure regulation. Normal range, 1.7 to 2.2 mg per deciliter. Hypermagnesemia. Causes: renal failure, reduced excretion. Excessive intake, overuse of magnesium-containing antacids or laxatives. Adrenal insufficiency, Addison's disease. Hypothyroidism, decreased renal clearance of magnesium. Symptoms: nausea, vomiting, muscle weakness, hypotension, bradycardia, respiratory depression, cardiac arrest. Hypomagnesemia. Causes: malnutrition, poor intake of magnesium-rich foods. Chronic alcoholism, poor dietary intake and increased renal excretion. Diarrhea or vomiting, loss of magnesium. Diuretics, increased renal excretion. Hyperaldosteronism, increased renal excretion. Proton pump inhibitors, long-term use. Diabetes mellitus. Symptoms: muscle cramps, tremors, seizures, arrhythmias, hypocalcemia, hypokalemia, personality changes. 6. Phosphate. Purpose: essential for bone mineralization, energy production ATP, mineral metabolism, kidney and cellular function. Normal range, 2.5 to 4.5 mg per deciliter. Hyperphosphatemia. Causes: chronic kidney disease, impaired phosphate excretion. Hypoparathyroidism, reduced PTH leads to phosphate retention. Tumor lysis syndrome, release of phosphate from lysed cells. Excessive intake, supplements or phosphate-containing laxatives. Symptoms: muscle cramps, tetany, calcification of soft tissues, itching, arrhythmias. Hypophosphatemia. Causes: hyperparathyroidism, increased renal phosphate excretion. Chronic alcoholism, poor intake and malabsorption. Refeeding syndrome, sudden shift of phosphate into cells. Malnutrition, inadequate intake. Respiratory alkalosis, increased cellular uptake of phosphate. Diuretic use. Severe burns. Symptoms: weakness, bone pain, respiratory failure, rhabdomyolysis, confusion, seizures. 7. Iron. Serum ferritin. Purpose: key component of hemoglobin, essential for oxygen transport. Normal range, 30 to 400 nanograms per milliliter. Hyperferritinemia. Causes: hemochromatosis, genetic condition causing excessive iron absorption. Chronic inflammation, rheumatoid arthritis, infections, cancer. Liver disease, cirrhosis, hepatitis. Repeated blood transfusions, thalassemia, sickle cell disease. Iron overload from supplements, excessive intake. Symptoms: joint pain, fatigue, weakness, liver disease, diabetes, heart disease, skin discoloration, bronze or gray. Iron deficiency. Causes: blood loss, gastrointestinal bleeding, heavy menstruation. Poor dietary intake, insufficient iron-rich foods. Malabsorption, celiac disease, gastric bypass surgery. Increased demand, pregnancy, growth spurts. Chronic kidney disease, reduced erythropoietin production. Symptoms: fatigue, weakness, pale skin, shortness of breath, brittle nails, pica craving non-food items, restless legs syndrome. 8. Zinc. Zn. Purpose: supports immune function, wound healing, DNA synthesis and cell division. Normal range, 60 to 120 g per deciliter. Zinc toxicity. Causes: excessive supplementation, overuse of zinc supplements. Inhalation of zinc oxide, from industrial exposure. Consumption of contaminated water or food, from galvanized containers. Symptoms: nausea, vomiting, abdominal pain, diarrhea, headaches, immune suppression, copper deficiency. Zinc deficiency. Causes: inadequate dietary intake, poor intake of zinc-rich foods. Malabsorption syndromes, celiac celiac disease, Crohn's disease. Chronic liver disease, impaired zinc metabolism. Chronic diarrhea, loss of zinc. Alcoholism, impaired absorption and increased excretion. Symptoms, growth retardation, hair loss, diarrhea, delayed wound healing, taste disturbances, impaired immune function.
Diabetes status. Fasting glucose level, HbA1c. 1. Fasting glucose. Blood sugar. BS. Purpose, measures blood glucose levels after an overnight fast, used to diagnose diabetes. Normal range, 70 to 99 mg per deciliter. Hyperglycemia. Causes, type 1 diabetes, autoimmune destruction of insulin-producing cells. Type 2 diabetes, insulin resistance and impaired insulin secretion. Stress. Hyperglycemia, acute illness or stress can elevate glucose levels. Cushing's syndrome, excess cortisol increases blood sugar. Medications, steroids, diuretics, antipsychotics. Pancreatitis, inflammation can affect insulin production. Symptoms, increased thirst, frequent urination, fatigue, blurred vision, recurrent infections, weight loss, slow healing of wounds. Hypoglycemia. Causes, insulin overuse, excessive insulin administration. Insulinomas, tumors of the pancreas that secrete insulin. Addison's disease, adrenal insufficiency can lead to low blood glucose. Severe liver disease, impaired glycogen storage and release. Medications, sulfonylureas, beta blockers, quinine. Symptoms, shakiness, sweating, dizziness, confusion, irritability, palpitations, fainting, seizures. 2. Hemoglobin A1c. HbA1c. Purpose, reflects average blood glucose levels over the past 2 to 3 months, used to diagnose and monitor diabetes. Normal range, less than 5.7%. Elevated HbA1c. Causes, uncontrolled diabetes, poor blood sugar control over time. Chronic hyperglycemia, persistent high blood glucose levels. Iron deficiency anemia, falsely elevates HbA1c. Chronic kidney disease, uremia can cause falsely high readings. Decreased HbA1c. Causes, recent hypoglycemia, frequent low blood sugar episodes. Hemolytic anemia, shortened red blood cell lifespan reduces HbA1c. Acute blood loss, reduced red blood cell mass. Chronic kidney disease, certain conditions can cause falsely low readings.
Pancreas function. Amylase, lipase. Symptoms of pancreatic disease. Severe abdominal pain, especially upper abdomen, bloating, nausea, vomiting, fever, rapid pulse, and tenderness in the abdomen, chronic diarrhea, weight loss, steatorrhea, fatty stools, and malnutrition. 1. Amylase. Purpose, amylase is an enzyme produced by the pancreas and salivary glands that helps digest carbohydrates. It is used to diagnose and monitor acute and chronic pancreatitis and other pancreatic disorders. Normal range, 30 to 110 unit per liter. Hyperamylasemia. Causes. Acute pancreatitis, inflammation of the pancreas causes a significant rise in amylase levels. Chronic pancreatitis, persistent or recurrent inflammation of the pancreas. Pancreatic pseudocyst, a fluid-filled sac within or adjacent to the pancreas, often due to pancreatitis. Pancreatic cancer, tumors in the pancreas can elevate amylase levels. Gallstones, obstruction of the bile duct can lead to pancreatitis and elevated amylase. Peritonitis, inflammation of the peritoneum, often due to infection or injury. Gastrointestinal perforation, a tear in the wall of the GI tract can cause amylase to leak into the bloodstream. Mumps, viral infection affecting the salivary glands, increasing amylase levels. Hypoamylasemia. Causes. Chronic pancreatitis, long-term damage to the pancreas can lead to reduced amylase production. Cystic fibrosis, a genetic disorder affecting the exocrine glands, leading to low amylase production. Liver disease, severe liver dysfunction can reduce amylase levels. Pancreatic insufficiency, inadequate production of digestive enzymes due to damage or disease of the pancreas. 2. Lipase. Purpose: lipase is an enzyme produced by the pancreas that helps break down fats. It is primarily used to diagnose and monitor pancreatitis and other pancreatic conditions. Normal range, 0 to 160 unit pet-L. Hyperlipemia. Causes: acute pancreatitis, lipase levels rise significantly during an acute inflammation of the pancreas. Chronic pancreatitis, recurrent or persistent inflammation of the pancreas. Pancreatic cancer, tumors in the pancreas can cause elevated lipase levels. Cholecystitis, inflammation of the gallbladder, often associated with gallstones. Bowel obstruction, blockage of the intestines can lead to elevated lipase. Renal failure, kidney dysfunction can impair lipase clearance, leading to elevated levels. Peptic ulcer, a break in the lining of the stomach or duodenum may elevate lipase levels. Hypolipemia. Causes: pancreatic insufficiency, inadequate production of digestive enzymes due to pancreatic damage. Cystic fibrosis, a genetic disorder affecting the exocrine glands, reducing lipase production. Severe malnutrition, lack of essential nutrients may reduce enzyme production. Chronic pancreatitis, over time, chronic inflammation can lead to a decrease in lipase production.
Renal function. BUN, creatinine, GFR, urine protein. Symptoms of kidney disease: edema, swelling, particularly in the lower extremities and around the eyes. Fatigue, due to anemia or accumulation of waste products. Decreased urine output, indicates reduced kidney function. Hypertension, elevated blood pressure due to fluid retention and hormonal imbalances. Nausea. Vomiting, accumulation of toxins that the kidneys fail to filter out. Itching, due to high levels of phosphorus or other waste products in the blood. Confusion or difficulty concentrating, resulting from the accumulation of toxins. Shortness of breath, due to fluid buildup in the lungs or anemia. Muscle cramps, resulting from electrolyte imbalances. 1. Blood urea nitrogen. BUN. Purpose: measures the amount of nitrogen in the blood from urea, a waste product of protein metabolism, reflecting kidney function. Normal range, 7 to 20 mg per deciliter. BUN. Causes: chronic kidney disease. CKD, progressive loss of kidney function. Acute kidney injury. AKI, sudden loss of kidney function. Dehydration, reduced blood volume leads to concentrated bun levels. Heart failure, reduced blood flow to the kidneys. High protein diet, increased protein metabolism. Gastrointestinal bleeding, blood digestion increases urea. BUN. Causes: liver disease, impaired urea production. Malnutrition, insufficient protein intake. Overhydration, dilutes BUN levels. Severe muscle injury, reduced urea production due to muscle wasting. 2. Creatinine. Purpose: indicates kidney function by measuring the waste product of muscle metabolism. Normal range, 0.6 to 1.2 mg per deciliter for men, 0.5 to 1.1 mg per deciliter for women. Creatinine. Causes: chronic kidney disease. CKD, gradual kidney function loss. Acute kidney injury. AKI, sudden kidney function loss. Severe dehydration, concentrated blood levels. Rhabdomyolysis, muscle breakdown releases creatinine. Obstructive uropathy, blockage in the urinary tract. Heart failure, reduced kidney perfusion. Creatinine. Causes: reduced muscle mass, less muscle produces less creatinine. Severe liver disease, reduced creatinine production. Pregnancy, increased kidney filtration rate. 3. Glomerular filtration rate. GFR. Purpose: estimates kidney function by calculating the rate at which the kidneys filter waste from the blood. Normal range, more than 90 ml pet men per 1.73 square meters. GFR. Causes: chronic kidney disease. CKD, progressive decline in kidney function. Acute kidney injury AKI, sudden decline in GFR. Diabetes mellitus, leading to diabetic nephropathy. Hypertension, damaging kidney blood vessels. Glomerulonephritis, inflammation of the kidney's filtering units. Polycystic kidney disease, genetic disorder causing cyst formation. Kidney stones, blocking urinary flow and increasing pressure in kidneys. 4. Urine protein. Proteinuria. Purpose: detects excess protein in urine, a sign of kidney damage. Normal range, less than 150 mg per day. Urine protein. Causes: chronic kidney disease. CKD, damage to the kidney's filtering units. Diabetic nephropathy, kidney damage due to diabetes. Hypertensive nephropathy, kidney damage due to high blood pressure. Glomerulonephritis, inflammation of the kidney's filtering units. Lupus nephritis, kidney inflammation caused by systemic lupus erythematosus. Multiple myeloma, cancer of plasma cells leading to protein overproduction. Preeclampsia, high blood pressure and proteinuria during pregnancy. 5. Electrolytes. Sodium, potassium, calcium, phosphorus. High K hyperkalemia, can indicate kidney failure, as the kidneys regulate potassium excretion. High P hyperphosphatemia, indicates poor phosphate excretion due to kidney failure. Low Na hyponatremia, may result from kidney conditions like nephrotic syndrome or chronic kidney disease. Low Ca hypocalcemia, often seen in chronic kidney disease due to poor calcium and vitamin D metabolism.
Liver function. AST, ALP, GGT, bilirubin. Symptoms of liver disease: jaundice, yellowing of the skin and eyes due to high bilirubin levels. Fatigue, common in chronic liver disease due to poor metabolism and energy production. Abdominal pain/swelling, due to liver enlargement or fluid buildup. Ascites. Nausea. Vomiting, resulting from toxin accumulation. Dark urine, high bilirubin levels can cause darker urine. Pale stools, indicates a lack of bile in the stool, often due to bile duct obstruction. Easy bruising. Bleeding, due to impaired production of clotting factors. Itching, high bile salts in the blood can cause skin itching. Confusion. Encephalopathy, accumulation of toxins can affect brain function. 1. Alanine aminotransferase. Purpose: measures liver enzyme levels, indicating liver cell damage. Normal range, 7 to 56 unit per liter. Causes: hepatitis. Viral or alcoholic, liver inflammation. Non-alcoholic fatty liver disease. NAFLD, fat accumulation in the liver. Cirrhosis, scarring of the liver. Liver toxicity, due to certain medications. For example, acetaminophen overdose. Hemochromatosis, excess iron accumulation in the liver. Autoimmune hepatitis, the immune system attacks liver cells. Wilson's disease, copper accumulation in the liver. Liver tumors, primary liver cancer or metastasis. 2. Aspartate aminotransferase. AST. Purpose: another enzyme indicating liver damage, also found in other tissues like heart and muscles. Normal range, 10 to 40 unit per liter. AST. Causes: hepatitis, inflammation of the liver. Cirrhosis, advanced liver scarring. Liver tumors, cancerous growth in the liver. Alcoholic liver disease, chronic alcohol use damaging liver cells. Muscle injury, since AST is also present in muscles. Heart attack, AST rises in myocardial infarction. Biliary obstruction, blockage in the bile ducts. 3. Alkaline phosphatase. ALP. Purpose: measures levels of an enzyme found in the liver, bile ducts, and bones. Normal range, 44 to 147 unit per liter. ALP. Causes: cholestasis, blocked bile flow in the liver or bile ducts. Liver cirrhosis, advanced liver scarring. Liver cancer, tumors blocking bile ducts. Bone disorders, conditions like Paget's disease or bone metastases. Primary biliary cholangitis, autoimmune bile duct destruction. Sarcoidosis, inflammatory disease affecting multiple organs, including the liver. 4. Gamma-glutamyl transferase. GGT. Purpose: an enzyme that helps detect bile duct issues and alcohol-related liver disease. Normal range: 9 to 48 unit per liter. GGT. Causes: alcoholic liver disease, alcohol-induced liver damage. Cholestasis, blocked bile ducts. Liver tumors, both benign and malignant tumors. Hepatitis, inflammation of the liver. Pancreatitis, inflammation of the pancreas affecting the liver. Congestive heart failure, can lead to liver congestion and damage. Cirrhosis, advanced liver disease. 5. Bilirubin. Total and direct. Purpose: measures bile pigment levels. High levels cause jaundice and indicate liver dysfunction or hemolysis. Normal range: total bilirubin, 0.1 to 1.2 mg per deciliter. Direct bilirubin, 0.1 to 0.4 mg per deciliter. High bilirubin. Causes: hepatitis, liver inflammation leads to reduced bilirubin processing. Cirrhosis, impaired liver function causes bilirubin buildup. Biliary obstruction, blocked bile ducts lead to bilirubin accumulation. Hemolysis, excessive red blood cell breakdown. Gilbert syndrome, genetic condition with mild hyperbilirubinemia. Liver tumors, obstruction of bile flow. 6. Lactate dehydrogenase. LDH. Purpose: enzyme present in many body tissues, including the liver. High levels indicate tissue damage. Normal range: 140 to 280 unit per liter. LDH. Causes: hepatitis, liver inflammation. Liver cirrhosis, advanced liver scarring. Liver tumors, malignant or benign growths. Hemolytic anemia, red blood cell breakdown. Myocardial infarction, heart tissue damage. 7. Albumin. A protein produced by the liver. Low levels indicate liver dysfunction or malnutrition. 8. Prothrombin time. PT and International Normalized Ratio. INR measures blood clotting ability. Prolonged PT. INR suggests liver dysfunction or vitamin K deficiency.
Cardiac function. Troponin, BNP, CKMB, myoglobin, lipid panel. Symptoms of heart disease. Chest pain. Angina, discomfort or pain in the chest, often indicating coronary artery disease. CAD. Shortness of breath, difficulty breathing, which may be due to heart failure or other cardiac conditions. Palpitations, irregular or rapid heartbeats, often associated with arrhythmias. Edema, swelling, particularly in the legs, ankles, or feet, due to fluid retention in heart failure. Fatigue, common in various forms of heart disease, especially after a heart attack. Persistent tiredness or weakness, common in heart failure. Syncope. Fainting, sudden loss of consciousness, which can indicate arrhythmias or other cardiac issues. Dizziness, lightheadedness that may result from poor cardiac output or arrhythmias. Nausea and vomiting, can accompany myocardial infarction. Sweating. Diaphoresis, profuse sweating is often a symptom of myocardial infarction. 1. Troponin. Purpose: cardiac biomarker used to diagnose myocardial infarction, heart attack, and assess the extent of cardiac injury. Normal range, less than 0.04 nanograms per milliliter. High troponin. Causes: myocardial infarction, acute heart attack. Myocarditis, inflammation of the heart muscle. Heart failure, particularly acute or decompensated heart failure. Pulmonary embolism, can cause right ventricular strain and elevate troponin. Severe hypertension, high blood pressure causing heart strain. Chronic kidney disease, reduced clearance leading to elevated troponin. Cardiac surgery or procedures, cardiac interventions can elevate troponin temporarily. 2. B-type natriuretic peptide, BNP, and N-terminal proBNP, NT-proBNP. Purpose: biomarkers used to diagnose and monitor heart failure. Normal range: BNP, less than 100 pg per milliliter. NT-proBNP, less than 300 pg per milliliter. High BNP. NT-proBNP. Causes: heart failure, Elevated levels indicate heart failure severity. Acute coronary syndrome can be elevated during an acute coronary event. Atrial fibrillation associated with higher levels due to atrial stretch. Pulmonary hypertension, increased pressure in the pulmonary arteries. Renal failure, reduced clearance of BNP. NT-proBNP. Severe infections, sepsis can elevate levels due to cardiac stress. 3. Creatine kinase MB. CKMB. Purpose: CKMB is a specific isoenzyme of creatine kinase found primarily in cardiac muscle. It is used to diagnose myocardial infarction, heart attack, and assess the extent of cardiac muscle damage. Normal range, 0 to 5 nanograms per milliliter or 0 to 3 g per liter. High CKMB indicates cardiac muscle damage. Causes: myocardial infarction, heart attack. CKMB levels rise 3 to 6 hours after a heart attack, peak at 12 to 24 hours, and return to normal within 48 to 72 hours. This pattern helps in diagnosing recent myocardial infarction. Myocarditis, inflammation of the heart muscle, can cause elevated CKMB levels. Cardiac surgery or procedures, any intervention involving the heart, like bypass surgery or angioplasty, can elevate CKMB due to temporary muscle damage. Cardiac trauma, injury to the heart, such as from blunt chest trauma or a severe fall, may increase CKMB. Severe arrhythmias, prolonged or severe abnormal heart rhythms, especially those leading to insufficient blood flow to the heart muscle, can elevate CKMB. Heart failure, acute or decompensated heart failure can cause mild to moderate increases in CKMB. Inflammatory heart conditions, conditions like pericarditis, though more commonly associated with troponin elevation, can sometimes cause a mild increase in CKMB. 4. Myoglobin. Purpose: myoglobin is a protein found in muscle tissue that binds oxygen. It is released into the bloodstream when muscle tissue is damaged. Normal range, 0 to 85 nanograms per milliliter. High myoglobinemia. Causes: rhabdomyolysis, severe muscle injury or breakdown, often due to trauma, intense exercise, or drug use. Myocardial infarction. Heart attack, myoglobin is released from damaged heart muscle cells. Muscle inflammation, conditions such as myositis or polymyositis. Severe burns, extensive muscle damage releases myoglobin into the blood. Seizures, prolonged or severe seizures can cause muscle breakdown. Electric shock causes direct muscle injury. Crush injuries, extensive muscle damage from being trapped or compressed. Extreme physical activity, particularly in untrained individuals or during heat stroke. Carbon monoxide poisoning causes muscle hypoxia leading to myoglobin release. Typical symptoms: muscle pain and weakness, dark, red, or cola-colored urine from myoglobinuria, fatigue, fever in cases of infection or inflammation, abdominal pain, nausea, and vomiting, confusion in severe cases. Low myoglobin. Conditions leading to muscle atrophy, extended immobility, neuromuscular diseases, or conditions like muscular dystrophy. Certain medications. Some medications may lower myoglobin levels, though this is less commonly observed clinically. Chronic illness, long-term conditions leading to muscle wasting, such as chronic heart failure or cachexia. 5. Lipid panel. Purpose: measures cholesterol levels to assess the risk of coronary artery disease. Low HDL, associated with a higher risk of cardiovascular disease. High LDL, increases the risk of atherosclerosis and coronary artery disease. High triglycerides, linked to pancreatitis and increased cardiovascular risk. Dyslipidemia, abnormal lipid levels indicating increased cardiovascular risk.
ABG, pH, PaO2, PaCO2, HCO3, Be, LAC. Purpose: ABG analysis is used to measure the levels of oxygen O2, carbon dioxide CO2, bicarbonate HCO3, and the pH of arterial blood. It helps evaluate gas exchange in the lungs and the acid-base status of the blood, crucial for diagnosing and managing conditions affecting the respiratory, renal, and metabolic systems. 1. pH. Normal, 7.35 to 7.45. Acidemia, pH less than 7.35. Alkalemia, pH more than 7.45. 2. PO2. Normal, 75 to 100 millimeters of mercury. Low O2 hypoxemia. Causes: pulmonary disease, COPD, pneumonia, pulmonary edema, pulmonary fibrosis. Cardiac disease, congenital heart defects, heart failure. Hypoventilation, due to drug overdose, neuromuscular disorders. High altitude, decreased oxygen availability. Symptoms: shortness of breath, cyanosis, confusion, tachycardia. High O2 hyperoxia. Causes: excessive oxygen therapy, hyperbaric oxygen therapy. Symptoms: may not cause symptoms if mild, if severe, could lead to oxygen toxicity. 3. PaCO2. Normal, 35 to 45 millimeters of mercury. Low CO2. Hypocapnia. Respiratory alkalosis. Causes: hyperventilation, anxiety, panic attack, fever, pain, sepsis, pulmonary embolism. Overzealous mechanical ventilation. Symptoms: dizziness, tachypnea, lightheadedness, tetany. Muscle cramps and spasms, paresthesias. Tingling sensations. Compensation: kidneys excrete HCO3 may take days. High CO2. Hypercapnia. Respiratory acidosis. Causes: acute, severe asthma, drug overdose, airway obstruction. Hypoventilation, COPD, drug overdose, neuromuscular disorders. Obstructive lung disease. Central nervous system depression. Symptoms: confusion, lethargy, hypoventilation, shortness of breath, headache, flushed skin. Compensation: kidneys increase HCO3 reabsorption. May take days. 4. HCO3. Normal, 22 to 26 MEq per liter. Low HCO3. Metabolic acidosis. Causes: diabetic ketoacidosis, accumulation of keto acids due to insulin deficiency. Renal failure, inability of kidneys to excrete acid or reabsorb bicarbonate. Lactic acidosis, accumulation of lactate due to tissue hypoxia. Diarrhea, loss of bicarbonate-rich fluids. Ingestion of acids, methanol, ethylene glycol poisoning. Symptoms: Kussmaul breathing. Deep, labored breathing, rapid breathing, confusion, fatigue, nausea. Compensation: hyperventilation to decrease PaCO2. Kussmaul respiration. High HCO3. Metabolic alkalosis. Causes: vomiting or nasogastric suction, loss of hydrochloric acid. Diuretic therapy, loss of potassium and hydrogen ions. Hypokalemia, shift of hydrogen ions into cells. Excessive bicarbonate intake, overuse of antacids. Symptoms: muscle twitching, hand tremors, nausea, confusion, seizures. Compensation: hypoventilation to increase PaCO2. 5. Base excess. B. Normal, -2 to +2 MEq per liter. High positive B more than +2. Indicates metabolic alkalosis, or compensation for respiratory acidosis. Low negative B less than -2, indicates metabolic acidosis, or compensation for respiratory alkalosis. Special cases in ABG interpretation. 1. Mixed acid-base disorders. Occur when two primary acid-base disorders coexist. Example, COPD. Chronic respiratory acidosis with diuretic use. Metabolic alkalosis. 2. Compensatory mechanisms. The body tries to compensate for a primary acid-base disturbance to normalize pH. Respiratory compensation, rapid changes in PaCO2 to compensate for metabolic disturbances. Metabolic compensation, slower adjustments in HCO3 by the kidneys to compensate for respiratory disturbances. 3. Oxygen-hemoglobin dissociation curve. Describes the relationship between PaO2 and SO2. Shift to the right, occurs in conditions like acidosis, hypercapnia, increased 2,3 dPg, which promote oxygen release to tissues. Shift to the left, occurs in conditions like alkalosis, hypothermia, decreased 2,3 dPg, which increase hemoglobin's affinity for oxygen.
Tumor markers. AFP, CEA, PSA, CA125, CA19-9, CA15-3. Normal ranges. AFP, less than 10 nanograms per milliliter. CEA, less than 3 nanograms per milliliter for non-smokers, less than 5 nanograms per milliliter for smokers. PSA, less than 4 nanograms per milliliter. CA125, less than 35 unit per milliliter. CA19-9, less than 37 unit per milliliter. CA15-3, less than 30 unit per milliliter. High alpha fetoprotein AFP. Liver, non-seminimatous testicular, ovarian cancer. Germ cell tumors, chronic liver disease. Pregnancy. Symptoms. Abdominal pain, jaundice, weight loss, abdominal swelling. High carcinoembryonic antigen. CEA. Colorectal, breast, lung, pancreatic, gastric, and thyroid cancers. Liver disease. Inflammatory bowel disease. IBD, pancreatitis, liver disease, and in smokers. Symptoms. Weight loss, fatigue, blood in stool, changes in bowel habits, abdominal pain. High prostate-specific antigen. PSA. Prostate cancer, benign prostatic hyperplasia, prostatitis. Symptoms. Difficulty urinating, frequent urination, blood in urine or semen, pelvic discomfort. High cancer antigen 125. CA125. Ovarian, endometrial, fallopian tube, peritoneal cancers, endometriosis, pelvic inflammatory disease, PID, menstruation, pregnancy. Symptoms. Abdominal bloating, pelvic pain, difficulty eating, frequent urination. High cancer antigen. CA19-9. Pancreatic, biliary tract, colorectal, gastric cancers. Pancreatitis, bile duct obstruction, cirrhosis. Symptoms. Jaundice, abdominal pain, weight loss, loss of appetite. High cancer antigen 15-3. CA15-3. Breast, lung and ovarian cancers. Benign breast conditions, liver disease, tuberculosis. Symptoms. Breast lump, changes in breast shape or size, skin changes, nipple discharge.